welcome everyone to our December edition of the Evidence-Based Services Committee from the Child and Adolescent Mental Health Division, our quarterly roundtable. Today we have the pleasure of having two wonderful presenters. I'll do an introduction in a little bit, but I'll first start off with housekeeping. One housekeeping item, whichever email that you use to register for today's roundtable, please be on the lookout for a feedback survey that we will be sending to that specific email address. If you have signed up to receive social work CEUs, the CEUs will be awarded based on both your time in the webinar today and your completion of the survey. In terms of time in the webinar, you will be expected to attend at least 90% of today's roundtable webinar to be considered for the CEUs. However, whether or not you signed up for CEUs, we would greatly appreciate it if you could fill out the satisfaction survey at the end to give us feedback and improvement ideas for making the next roundtable even better. In addition, HPA, Hawaii Psychological Association, with the support of the Hawaii Behavioral Health Connection, a program of HPA, is co-sponsoring this roundtable and offering free continuing education credits for its HPA members. So a deep note of gratitude and appreciation to HPA and the Hawaii Behavioral Health Connection. Thank you very much. I'll do a quick introduction of our keynote presenters, and then I'll turn it over to them. So first, I'd like to introduce Dr. Stephanie Campbell. What I'm about to read is what she told me to read. Her first sentence is, I'm slightly uncomfortable reading her first sentence, but she describes herself as a half Filipina, half white, small, fat, able-bodied, cisgender daughter of an immigrant who grew up in a one stoplight town in Arkansas. She is also a licensed clinical psychologist in Hawaii and nationally certified school psychologist who serves as the crisis liaison and community trainer for the Hawaii DOH Child and Adolescent Mental Health Division. Dr. Stephanie participates in systems-level interventions for statewide mental health crisis response and develops free training opportunities for community members and providers. She is also the co-founder and co-owner of Something Simple Counseling. Her research is largely focused on minoritized identities, their influence on mental health, and practical ways to reduce implicit biases. She is especially interested in how experiences of trauma, race, body image, and weight stigma affect the well-being of children and adolescents, particularly in relation to implications of culture, socioeconomic status, power, privilege, and gendered societal expectation. Outside of work, Dr. Stephanie enjoys podcasts, painting by number, ocean paddling, video games, and cooking without recipes. So welcome and thank you very much, Dr. Campbell. Now, a quick introduction for Dr. Alexandria King, who currently serves as the clinical lead at the East Hawaii Family Guidance Center on the Big Island, where she provides clinical oversight for children and families seeking intensive mental health services through CAMD. In addition to her work as a clinical lead, Dr. Alex is deeply committed to improving systems-level care, with particular focus on training, supervision, and consultation for current and future providers. She firmly believes that by enhancing the support systems for therapists, the quality of care provided to clients is ultimately elevated. In addition to her role as clinical lead, Dr. Alex also provides supervision to both master's and doctoral level students, collaborates with Dr. Stephanie in her work to provide free community trainings, and has also established CAMD's PC Care program, which has included training and certification of 10 PC Care providers and over 50 families through this modality since 2020. She is also a co-founder and co-owner of Something Simple Counseling. Outside of work, Dr. Alex enjoys cuddling up with her 5 dogs, knitting, and eating the food Dr. Stephanie cooks. So welcome both of you. Thank you for presenting today. And without further ado, we'll introduce one last thing. We'll introduce our keynote and discussant, Mr. David Gerber. We'll introduce him at the end when we turn it to the discussion portion. So, but I'll first turn it to Stephanie and Alex. Thank you.
Awesome. Thank you so much. for that great introduction. We are super excited for the opportunity to talk about the things we've learned, the adaptations we've made, and what we like and appreciate about PC care, how it is trauma responsive and caregiver led. But first, I want to give us a second. We've probably been running meeting to meeting for most of us all day, place to place. So go ahead and take a second to take a deep breath or two, acknowledge how you're feeling, what you're bringing into this space, and what you want to let go. We also want to acknowledge that every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. Some were brought here against their will, some were drawn to leave their distant homes in hope of a better life, and some have lived on this land for more generations than can be counted. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We contribute to this effort to acknowledge what has been buried by honoring the truth. We're on the ancestral lands of the Hawaiian Kingdom, and we acknowledge that Her Majesty Queen Liliuokalani yielded the Hawaiian Kingdom and these territories under duress and protest the United States to avoid the bloodshed of her people. We hope to live and work in solidarity to Malama Ka'aina and to live with aloha. All right, so overview for today, we will, forgot to take out that part about in California. We will be mentioning something that's happening in California that we'd love to bring here. So a little bit of overview there, but mostly we'll be introducing and explaining PC care, the philosophy and values that go into what we do with this intervention, what we've learned and the data we have from doing it here in Hawaii, and then have time for some panel discussion with some folks who have participated in PC care. Go ahead and give you a minute to drop in the chat some whatever you'd like to share. So here are some prompts for your consideration. If you are a provider, what parts of working with caregivers are you most comfortable with? And what parts of working with parenting caregivers or younger kids make you feel uncomfortable or hesitant? Or another way to say that is, what do you maybe try or just so happen to end up avoiding if you can? You can think about this question as consider what kind of sessions you might secretly dread or you secretly hope get canceled sometimes. And yeah, this is a little bit of a vulnerable exercise. If you feel comfortable sharing something in the chat, I encourage you to do so. If you are a caregiver, whether or not you are a provider, we're curious, what behaviors with youth, children and youth do you find easiest to manage and which are more challenging to manage? Just as a reminder, Andrea mentioned this in the chat, but if you want everyone to see it, you have to choose everyone from the chat. Otherwise, it'll just go to the hosts and panelists. One person said relatability. I know sometimes we have, so with Alex and I supporting the training of our practicum and students and pre and postdoctoral interns, sometimes it's like folks coming in who are not parents themselves and they get kind of nervous of like, oh, I'm not a parent. Like, why are these caregivers going to listen to me? What do I have to tell them in this therapy? Anything else you want to add, Alex, about some of the nervousness we experience or encounter?
Yeah, I mean, probably on that similar line, what made me most uncomfortable was like, if we're in a parenting intervention where we have to improve things, really confronting what's not working and suggestions to improve. And I think that always feels a little uncomfortable. And I think PC Cares really supported my ability to do that, but was definitely something that I was like, oh, I don't know that I want to tell this parent what to do different. We're kids, we're used to that a little bit more and giving those corrections.
Totally. And I'll just share on behalf of both of us. Neither of us are people who have our own children at this time either. Feel free to go ahead and drop anything you'd like in the chat, but we'll go ahead and get started with an overview of what is PC care.
Right, super happy to share this with you all. So I'll give kind of the brief definition and then we'll spend some time diving deeper into it as well. But At its like basic core, PC care is a brief dyadic intervention, so it takes place with the child and whoever their primary caregiver is at that time, whether that's their bio parent, a foster parent, TFH, if they're in one of our programs, we can work with whoever's their primary caregiver. And the goal is really to improve the relationship together and then also reduce difficult or disruptive behaviors by increasing the positive communication between the parent and the child, supporting self-regulation and coping skills, again, for both, and then also teaching effective behavior management strategies very directly. And to get into a little bit of the history, so PC Care was developed in 2016 at the UC Davis Care Center. That's where I came from prior to my internship here in Hawaii. And that was the folks who trained me, which was really exciting. They're like the experts of it, of course. It was named a trauma intervention by the NCTSN, the National Child Traumatic Stress Network. And you can see that long list of publication history that we would be happy to pass along for anyone who's curious on reading more. And right now it is rated under the California Evidence-Based Clearinghouse as a 3 with promising research, specifically for like child welfare relevance. That's a big focus in Sacramento. And I think most of that is because it's still a newer intervention, just wanting to collect more data and intervention long-term.
They do have a number of RCTs going on right now, and so there's new research coming out as we go.
Absolutely. And then for a little background on how it got here. So like I mentioned, I was trained by the folks at the UC Davis Care Center. And when I got matched here in Hawaii, they were so lovely and said, well, we have to make you a trainer of this intervention so you can bring it out there. And so to our knowledge, that's how it kind of ended up here to be able to be scaled. I don't know if there were other providers of it prior to me being here, but I don't think so. Folks might have been familiar with what's called PCIT, parent-child interaction therapy, and PC Care is a 7-week version of that. So they're very similar, but there are some differences in how we approach it. So I came out as a pre-doc intern in 2020. I had my own clients, and I was really lucky to be able to train some folks while I was out here that year. And I've been very much supported by my supervisors, my higher ups, and my center at East Hawaii to be able to expand this program. So I trained Stephanie when she came over as an intern as well. And I have yearly now, we've been training all of our students who come through. And there's been an effort to kind of train more of our community providers like intensive in-home therapists and others who would be interested to get trained in this and support our community. Since then, we've had over 50 families participate in PC Care, with about 40, I think a little over 40 have completed it. And we'll talk about the data of like what our retention rates are, but pretty good retention rates for an evidence-based intervention. Oh, yep. Thank you, Malin. Malin was trained by me, which was lovely. And then, sorry, I lost my train of thought. Oh, yeah. There's only a couple of interventions really available to kids in this age range. So PC Care does serve kids 1 to 10, and we do have a teen version now, so we can go up to 18. But really that like 3 to 10-year-old range can be a hard population to meet the needs of. I think the primary intervention through our system at CAMD is with intensive in-home. So it's been really nice to have another type of intervention in there that can provide, I think, really strong support and in such a short amount of time because it's much more accessible to our families. And again, we have really promising data that shows that it's been really like accepted by families who have done it, and it's been very helpful, and families, you know, report lower levels of stress and improved behaviors by the end. And initially, we only offered it through us at East Hawaii Family Guidance Center, but we've now been able to expand that statewide through CAMHD. And so we can offer it across the islands because this intervention primarily happens via Zoom. We can do it in person, and we definitely try to accommodate that when we can. But Zoom is honestly, in a lot of ways, more effective for this intervention because we're able to kind of be a little bit more separate. And we'll get into what I mean by that soon, because the way that this sessions are set up is a little bit unique. So you can see here, this is what a typical session looks like. It is very structured. So we know exactly what we should be doing at any given moment in the session. I'll just go briefly because I know not everyone's a provider, but just to give an overview, we spend the first 7-ish minutes checking in with the family, and we give a measure every week. Then we do a brief didactic where we teach the family new skills only for 10 minutes of the session, really to get a general overview. Most of the skills are skills families are heard of before and are familiar with, but just making sure we have a shared understanding and some exposure to it, because we really want to save the rest of the session for live in the moment practice. And I would say that is like the steak and potatoes of PC care, of what makes it different and special. So after we do our didactic, we observe them and play together for about 5 minutes and record their progress. And then we spend 20 minutes coaching the parent to use the skills we just taught them with their child right there in the moment. And so we practice through play, which is lovely. It's a really easy way for kids to learn new skills and practice when it's at lower levels. It's also a lovely and rich opportunity to see some of the real behaviors that families are navigating at home without their therapist there. You know, cleanup time is usually really challenging, or transitioning between toys can be a struggle. So we're able to practice real life skills through the mode of play. And then we help the family to understand how that's going to help them outside of playtime, even at school. I've seen kids who there's no behavior concerns at home, but school is a challenge, and we do PC care and school still gets better, which is great. And then after we've coached them for about 20 minutes, we spend about 10 minutes checking out to review progress. We have lots of measures in PC care, so we're always showing graphs and whatnot to our families so that they can see in the moment how much progress they're making, and we can assess their motivation and normalize when the challenges come up that they're there, and assess their motivation, and then, you know, close out together for the session. This next slide, again, I'll just be brief on this one, just a quick overview of all of the skills we learned. So you can see session 1 is very focused on the positive communication skills. We also tell parents some of the things we want them to avoid, like the words no, don't, stop, quit, not, or commands or questions. And then most of the other sessions are really focused on those behavior management strategies with some coping skills and co-regulation in there as well in session 2 and session 5. So really a good mix of things that we're able to give to families. In any given session, we're able to really address their behavioral concerns with the skills of that week. Then we do have some special appendices for PC care. So we have special protocols for kids who have a diagnosis or are suspected of having autism spectrum disorder and or intellectual or developmental disabilities. We have an appendix for children who have problematic sexualized behaviors. We have one for babies and toddlers, so anyone under 3. Now for visitation, so kids who are in foster care but are working towards reunification with the bio family, we're able to do 2 things with that one. The first is the foster family can go through full PC care as well. And then during visits with bio family, we can also have a PC care session then where we work on how can we make this time together as nice as it can be as we prepare to transition back home, so that the parent, you know, gets their kid back and has lots of skills in their tool belt. Like I mentioned before, we now have PC care for teens, so that would be that 11 through 18 group. We have it in Spanish, and we are now developing PC care for FASD. I'm co-authoring that with our intern from last year, Lydia, and we'll be working shortly. Stephanie, I know, is really invested in working on a protocol for families who are experiencing houselessness. And so they might be in more transition and don't have a stable place with consistent, even like toys that their kid can play with, and how we can navigate that really big thing that they're going through. All right. And Q&A that we always get. So how is PC care culturally sustaining? So of course, we're mindful of the different cultural backgrounds of our families, and we're supportive of their unique strengths. That's actually something we do right from pre-treatment. We ask the family, what are your values, your cultural values, your values as a parent that are really important to you to maintain? And we put that on their goal sheet with them so that we can be aware of it and incorporate it and have them just think a little bit more intentionally. We find a lot of families think about what they don't want to do when it comes to parenting, but sometimes haven't had the opportunity to think about, what do I want to do? What do I want to keep with me? We allow parents to use the words that make sense for them. So like I mentioned, we coach them, and part of that is I tell the family like word for word what I would like them to say. Most often, it's totally okay if they reword it for them right away, but sometimes if they're just missing the skill, I'll ask them to repeat it like me until they know how the skill feels for them, and then they can totally make it their own. We use labels and pronouns that they prefer, toys that are relevant to the family or culturally important. And I think what's really important here is that we focus on strategies that work for this family and their household. So even though we teach everyone all of the skills, we're really thoughtful about how we're tailoring the skills so that the family will actually use them. Because if I teach you how to use selective attention, but you're never ever going to use it, then I'm not going to beat a dead horse on that skill. I'm going to try and find what are the other skills that can get our desired outcome so that it works for you and your family and we see real outcomes. Okay. And then, like I mentioned, PC Care is a trauma-informed intervention. So we teach, and part of our goals of PC Care, we teach about the effects of trauma and the impact it has on children, how it might impact their relationships, their stress levels, and ability to regulate, and how it connects to difficult behaviors. That's something we do in our pre-treatment didactic, and it's something that we also bring as we go throughout PC Care, that we're touching on that as a consistent thread, so that when families know their child has experienced trauma, they can see how it might affect them and how the skills help. And of course, we talk about, the impact on relationships and why we want to really focus on the positive relationships. We know that not all kids who are traumatized develop full PTSD, but we also know that the caregiver-child relationship is one of the best protective factors. So enhancing that as much as possible is a huge goal. I mean, I think if parents take nothing else than special playtime together and using pride skills, like that is honestly a really good PC Care session. I would love for them to get all the other skills too, but if in 7 weeks that's all they get, that's really a good protective factor and going to do a lot for them. And of course, PC Care, we model non-avoidance. So we're going to talk about things very directly. And we also practice with like the coaching and being able to understand the child's response and being very direct. So I think that helps families understand how they can also navigate non-avoidance and create a space where their kid can talk about things that might have been uncomfortable and feel safe and know that they have this kind of safe and secure space to do that.
That's something too that we find is pretty helpful with our trainees, or even I would say for me and Alex too, when we were trained in this. You really don't have, the way I explain it to folks is we don't have time to mess around. We have 7 hours across 7 sessions. And if we are not addressing things right away, if we're avoiding the things we personally feel uncomfortable with or the family feels uncomfortable with, we're doing that out of our own comfort and not the help that they actually might benefit from.
Definitely. All right. And why be caregiver led? I mean, this is a huge piece of a trauma-informed approach. And you can see even here, these 3 pieces are directly from what is a trauma-informed approach, which we have a slide on later. But for us, it's really important to collaborate with the family. And kind of like Stephanie and I mentioned, some of our nervousness at the beginning was, having to come in and correct a family or give ideas and coach and how to support them to make change. But what's really important and what we want our families to know is we're not coming in to tell you how to be a parent, right? You will always know yourself and your child better than we ever could hope to. But what we are the expert in is child development, trauma, and behavior management, all of those things. So we want to collaborate as a team so we can marry those 2 pieces of information together, what you know about you and your family and what we know about trauma and child development. It's not a do as I say kind of treatment. It's us working as a team to solve this problem together. Choice is really important, honoring where the family is, what their preference is, while also holding reasonable expectations. A lot of our families have been through trauma themselves, and especially systemic trauma. Navigating some of our systems can be challenging and confusing, and they might not have felt like they had choice and voice in it in the past. And so we really like to prioritize that and make sure they know that their voice is at the forefront of this treatment. And we want to be empowering, affirming, and validating them to build self-efficacy, trust, confidence, all of those. And I think I touched on this already, but why do we do that in the moment coaching? It's really the crucial component of PC Care. It's where the magic happens. So we're able to coach them in using every single skill we taught them, like right there, instead of them having to take this information and go home and try it on their own without someone to let them know if they did it right. Was there a different way they could have approached it? Did they respond at the right moment? Did they see it through all the way? We're able to give a lot of real life feedback there. And we intentionally set up opportunities to work through a real life challenge not related to play. Go ahead, Steph.
Sometimes when we'll have a lot of the same information that we would give in any kind of like parenting group that we've done. We have a group that we've offered several times through QMD that's like caregiving after trauma, and it's not different information. But the huge difference is if you're in a group, parent attends a group for an hour and goes home, and just does their best with trying to apply those skills. Whereas when we're receiving live coaching, you don't have to wonder if you're doing it correctly. You don't have to hope that it works. But you're having a lot of in the moment feedback about what's this kid responding to? What are they not responding to? And maybe calling out things that they would have never noticed. Like things like, oh, you gave 3 commands right then, and the kid totally ignored you. And as soon as you praised him, did exactly what you wanted. So things like that actually are the change agent, I think, is being able to point it out with directness, but with gentleness in a way that can be listened to well, I think.
Definitely. All right. And then what are the
Sorry.
benefits?
Yeah. Well, you're rolling. You're doing a great job, Alex. I can help too. So, benefits of participating in PC care. There are many. For parenting caregivers, we really see people grow in their confidence in managing behaviors. And I think for a lot of the types of referrals that land with CAMHD, and if you're unfamiliar with our service, um, it's you have to be pretty elevated. You have to have struggles going on in multiple areas of functioning, multiple settings. It's not your kind of typical anxiety or depression stuff. It's often a little bit higher concerns or pretty significant behavior going on. And so sometimes when families are with us, they're like, oh my gosh, it's out of control. I'm overwhelmed. I can't do anything. This 5-year-old is running the household essentially because everyone's too scared of what's going to happen. But through that, connecting the dots for them in coaching, we can actually show them that they have a ton of influence on what's happening in their home, and they have a ton of influence on how these behaviors manifest. It's very opposite of this idea sometimes I feel like parents might have where, like, okay, I'm gonna drop my kid off at therapy, you go ahead and fix them and just go ahead and give them back when they're fully cooked and ready. And it's absolutely not that. So you're making them a very active participant. One thing that Alex and I like to say is that we want it to feel like therapy is happening with them and not to them. And it's more of we want it to be us all against a problem rather than me versus you, which I think, unfortunately, is what our families who have been in systems like the child welfare system and things like that, sometimes it feels like them versus the system. And we do not want it to feel like that for our participants. We help them feel that sense of agency and control and give them skills to be able to regulate themselves and stay more calm when they're interacting with their child. For everybody involved, we hope to see an improved relationship between caregiver and child, whatever that means to them. We ask specifically in the pre-treatment session, what does that look like? What is a relationship goal for you? We want to have them have space and time to have fun together. I like to share that that's one of my favorite parts of doing this is just watching adults learn to have fun and to play with their kid, because sometimes you're coming from a really stressful place. You got a lot going on. People are working multiple jobs. They're dealing with their own set of trauma, with their kids' reactions to trauma, and it feels chaotic. So having this thing where you're spending time together and being present make a huge difference. We're trying to incorporate stability and consistency, again, part of trauma-informed care, and providing a lot of psychoeducation to both caregiver and youth about development, about trauma, about the cycles that families get into sometimes that maintain disruptive behaviors. For the youth, we want to increase the sense of safety and help show the parent ways that they can help their child feel validated and feel important. All right, I want to just mention thank you for dropping a question in the Q&A. I dropped a link. It was a question about how to decide between PCAT and PC care. So please do look that link over, and if you have further questions, let us know. We'll now talk about some philosophy and background. So I want to give you a second to drop in the chat whatever first comes to mind when you hear the term old school parenting. What do you think of? Or if any of you panelists who have the ability to unmute, feel free to unmute and shout it out. Lickens?
Yeah, I was going to say more punitive.
Authoritarian.
Authoritarian, do what you're told, seen and not heard. Absolutely. Those are all very aligned with the things that we've noticed as well. So I hear this often. People say, oh yeah, don't talk back. Yeah, I was raised old school, or like, auntie is an old school caregiver, and it's kind of a little bit vague, but in general, it often means things like this. So, highly valuing discipline or accountability, respect for adults, elders, and authority, and really valuing obedience. Sometimes we see use of things like physical discipline, like lickings, spankings, whoopings. We have these toughen up techniques because the idea is the world is hard and tough. And so if I make it tough on my kid right now, they're going to be tough and ready for this hard, cold world that's going to try to beat them down. And an authoritarian, like you mentioned, authoritarian or strict approach. And the one that actually I think is really interesting that I've asked this question to many, many audiences, and I don't think anyone's ever said this upon the first question, is men less involved in child rearing. But I do kind of think about that as more like kind of old school traditional gender roles sometimes. I will say that that's not all of those other things really get in the way, and that's not one of the things that tends to get in the way, at least with the families that I've been working with here. Yeah, bribing your child for sure. And so a few reasons why those traditional strategies might not be working. These days in modern 2024 time, we know a lot more about how trauma works. We know how complex trauma manifests very differently than acute trauma. We know about intergenerational and historical trauma and how that's affecting generations way beyond whatever happened. We know a lot more about child development, what's instead of this idea of children being teeny tiny adults, they're not tiny adults. They're super fundamentally different. Some of that coming down to their brain functioning because they're still cooking. Their brains are still jello in some ways. They have a long way to go. We also know a lot more these days about effects of caregiver-child relationship and what that means. We're no longer putting babies in drawers as soon as they're born, right? We know that attachment matters and that the relationship can make a huge difference in behaviors. Another reason these strategies tend not to work so well is that a battle of wills feels more exhausting than helpful. If it comes down to child v adult who can hold out the stubbornness the longest, that's super tiring and probably a lot of honestly like wasted time. We're not using our time the best if we're just trying to out stubborn or out like last the other person's will to hold up their boundary or whatever it is. And then discipline based in fear or obedience is likely not communicating that family's core values. It might be a little unusual for someone to have the chance to reflect what are my core values. I think we did the burnout talk at one of these a while back, a few months ago, and we took a second to do a value. If you've come to some of my trainings, you might have seen this of a values card sort, or really taking time to reflect on your values. But that's kind of atypical. I would say that's not something we all make time for, but it is something we ask about in pre-treatment. What are your values as a caregiver? Because we want to be able to incorporate that, and that's part of how we make this intervention very culturally sustaining. But usually, trying to make your child afraid of you and afraid of consequences is not necessarily reflective of those things that are usually most important to families. The other thing we hear sometimes is, well, I or so and so, got hit a bunch as a kid and they turned out fine, or I turned out fine. And if I wanted to, I could potentially make that argument. I experienced lickings as a child, and I'm a doctor now, so I guess in the end it turned out okay. But this is the video that will show why I think that's not the strongest argument.
Someone commented on one of my previous videos and said, I hit my kids and they're doctors now. And we have to understand that good parenting is not measured by the college they get into or the job that they have. Do you know how many people with traumatic childhoods have great jobs and lots of accomplishments? The goal of parenting shouldn't be to create doctors and lawyers. We should put more focus on teaching children to create, build, and maintain meaningful relationships. We should put more focus on teaching children to understand themselves and their needs and to meet their needs in a healthy way. We should put more focus on helping children hone the skills of empathy, perspective taking, problem solving. But hey, if they're a doctor or lawyer, they may not be able to afford the time, but hopefully they can afford a good therapist that will help them spend the rest of their lives healing from the adults that hit and shamed them as a means of control.
So if you're not familiar with Mr. Chaz, I'm a big fan. He has a couple of videos in this presentation, actually, because I think he just does things very well and communicates some of what we're trying to say is it's really not about the ultimate outcome, right? There's some other things that happen in the middle that are probably avoidable. There are things that happen that were totally avoidable for me in my younger life if I hadn't been hit as a kid. And I can say that for my brother too. I can say that for all kinds of people I know who experienced similar kind of old school upbringing of overly strict obedience as number one kind of raising. So I will step onto my teeny tiny soapbox for just a moment, if you'll have me, to talk about why physical discipline is something that we should reconsider. And I personally argue that is something that we as providers have an ethical responsibility to know about and to have at least think through it. Even if you totally disagree with what I'm about to say, please consider it, if nothing else. Whatever you want to call it, spanking, lickings, whooping, smacking, kids who are physically disciplined have similar reactions to those who have experienced other types of childhood trauma. So it's a little bit wild to think about just spanking your kid, as normal as that feels, can give them the same traumatic responses as neglecting them or other kinds of abuse. Those kids also tend to have a lot more externalizing behaviors. So they're much more likely to hit others because it's been modeled for them. Adults hit kids and they show it's okay, it's acceptable, and kids can follow that. So of course I'm going to try to solve my problems or my whatever issues by hitting other people. The interesting thing to think about is that's not how we solve other problems typically in most adult interpersonal relationships. I work with Alex all the time. If we disagreed and I hit her, or even if I just like, I don't know, slapped her, I don't know, anything like that, that would be bizarre. That would be called assault. That would not be called a cultural choice. And that's kind of why I feel very strongly about physical discipline, because from my grad school training, I worked in schools for a while and no one wanted to touch this topic. No one ever wanted to bring it up. They didn't want to talk about it. They said that's a cultural choice that family's making and we're stepping way, way back. But I don't think that's really fair because we're totally disregarding a lot of history and colonization that went into that. Just because something is normal and typical where you grew up does not mean it's helpful. Where I grew up, all the way through high school, you could get spanked with a wooden paddle in schools. And I graduated high school in the aughts, like in 2009. That's wild. I have someone 1 year older than me who got spanked in school until she was 17. And so it was super normal where I grew up to get hit. However, we didn't think about why are we doing this? What's the tradition that led to this moment? And really taking a critical socio-historical look at it, groups with connections to colonization and slavery are more likely to use physical discipline. So I'll use myself as an example. On one side of my family, Filipino immigrants colonized for a long time by lots of folks. Okay. Colonization taught them how to hit each other as a means of control. The other side of my family is from rural Arkansas, where slavery was a thing back in the day. And even for the white folks, they hit people of color to control them. And so white folks also hit their own kids to control them. It's not a racial decision. It's a tradition that goes back to pretty problematic roots if we sit here for 1 second, investigate it. And so when we do something because we think it's a cultural choice without thinking about those roots, we're continuing a tradition that is pretty dark when there are a lot more effective ways to manage behaviors. So I will step off my tiny soapbox again, but I do have lots of great resources to share if you want to know more about some alternatives to lickings. So this is one alternative, compassionate caregiving, what you might call positive parenting. We stay away from terms like gentle parenting because the internet has taken that and done a lot of stuff with it. And I wouldn't say I agree with a lot of it. But compassionate caregiving is how Alex and I tend to conceptualize this for people because it directly speaks to the root of what we're trying to do. But to start out with what is absolutely not, it is not just permissiveness, the kid being in charge. It is not trying to be happy all the time. It's not giving no consequences. It's not what you see on social media. It's not just white people stuff. It's not white culture. And it's not selfish. It's not focused on being friends. But it is a lot of other things. Compassionate caregiving, we define as being strengths-based instead of fear-based. We define it as having effective, positive communication instead of things like bribery. We're using rewards to reinforce good choices and good behaviors. We want to also emphasize and praise those good behaviors much more than we're disciplining or having consequences for poor behaviors. We encourage folks to think about how can we teach Keiki to be thoughtful, independent people in the world and not to just obey or follow. Because when they are growing up in a culture, and we see this in a lot of high control groups or kids that grow up in, really, really high control religions or cults, that if they just learn to obey and follow and nothing else, they have no way to stand up for themselves in situations where they should. So in the situation like peer pressure or someone trying to assault them in some way, they don't have the skills to be resilient or make their own decisions if all they know is to obey. We want to help build resilience to keep them safe in those situations. And we do all of this by having a really thorough understanding of trauma and context. So if we don't have an understanding of that, we really don't have the information we need to be compassionate in our caregiving. This is a really excellent quote that we include in these trainings when we train PC care providers. And I like to include it in caregiving trainings as well. Our children need us to contain them, but not control them. And if you're coming from a trauma-informed lens, this makes a ton of sense, right? We're not trying to just take all the control and power and agency away from anyone, even if they are a child, but we're going to show them ways they can have agency appropriately. And containing and putting appropriate boundaries can help them learn that safety and build resilience. And this is a post that I found on social media once a while back that I liked. It's reasons for a child's behavior. What it seems like on the surface can be the kid is naughty, disrespectful, manipulative, they're a bad kid. But what can be going underneath are a lot of different things. They might have unmet needs. They might be under stress. They might just really need co-regulation. They might just have the brain development at a point where they can't process the information very efficiently and well. A lot of times kids are doing the best with the tools they have, and their tools are not very good yet. So that's why caregivers can have such an influence, and we really want to help caregivers unlearn through the things we're doing, not just by saying this. We want to help them unlearn beliefs like my kid is messed up, my kid is broken, my kid is bad, because we don't believe that, right? The kid is a product of a lot of different things, but they are fundamentally not bad or broken. And when parents or caregivers have that ideology, it's kind of tough to like allow your kid space to grow. So by showing them the agency and power they have and the ways they can influence their kid, everyone can grow a lot through that. This is also really important information for caregivers, is that your children need help to learn skills. They can't just do it on their own, but instead this is like a developmental model. And if some of you have been in like supervision that use a developmental model, this probably feels familiar, but it applies across the age range. So for example, do it for me, do it with me, help me do it, and then I can do it myself. So one example would be calming or breathing. If you're doing it for them, a parent can hold the child close to their chest and take calm breaths that can help the baby calm down. Do it with me. If they're young, you can do a breathing thing with them to help them cope and calm. Help me do it when they get a little older. You can just remind them, hey, here's a menu of some of your calming things. Please choose one. And I can do it myself. Hopefully they gain the skills to be able to calm on their own. All right. I think actually I'm going to skip this one for now. If we have time, we'll come back. But I just want to check in. What thoughts or reactions does anyone have to the content we just presented? If you have any questions, I'll check the Q&A. How does your philosophy about caregiving, especially if you're a provider, affect the work you do with youth or other roles that you have? And how, if at all, have you encountered cultural mistrust? If you feel like sharing, please feel free to drop in the chat, or if you're a panelist, feel free to unmute. Yeah, that's a great question. So someone in the chat said, I know it's just host and panelists, I'm going to read it aloud. I'm curious to understand what was the style of compassionate parenting exemplified outside colonization, if there were any traditions you could point to. And I can't say I have like a tradition. I think there have been places across the world, I'm sure, that parented in all kinds of ways, but I do have one very specific example that has to do where my family's from. And that's when the United States came and colonized, like they, I guess, liberated the Philippines from Spain, but then they colonized them too. There was a time when some scientists, like social scientists were going over to the Philippines to do some research on people and things like the type of way that they presented in school, what kind of education makes the type of person we want to make. But one example that sticks out to me from grad school was I learned about how Filipinos were criticized by white folks from the United States because they said, you're breastfeeding your children too much. What are you doing? That's way too much. You shouldn't be doing it that much. And now, decades later, we have this research to say, actually, breastfeeding is like kind of good and equally valid, if not, some people are very, very pro breastfeeding. So, I mean, that's not a parenting style, for example, but it's one example of how the colonizing mindset is like, okay, we know exactly, we're experts on this because we decided we're experts, not necessarily because we have data. And we're going to tell you what's right and what's wrong. So you probably should, they also criticize Filipinos for holding their children too much, being too close with them. And so I thought that was really fascinating. I was like, oh, these are all things that we want people to do. We want them to be close to their children. We want them to have an attachment and connection to them nowadays. But for no reason, you just said, please don't do that. Oh, this is a great question. What do you suggest when schools see the kids as bad or manipulative, especially when parents have more contextualized view of behavior? So, I mean, I'm trying to think of this I think about this from a perspective of parents all the time, but Alex, chime in if you have thoughts about the school. So, in terms of a parent, when we have some parents that view their children as manipulative or bad, and I think maybe similar things would apply for other adults in their lives, is that man, first we have to try to give people a second to step back. I think this is complicated when it comes to the schools because the school is a whole system. There are a lot of people involved. I know exactly what you mean, though, is that sometimes when a kid gets labeled as just a bad kid, that can follow them for a lot of years to come. And that's unfortunate. So I think in some cases, it probably takes like, I don't know what the word is, like a champion for that kid to like perspective take to help other people perspective take or to help them understand the context that this child is not a bad child. The child is reacting and most often doing the best they can with the tools they have, and their tools are not great. They need better tools. But yeah, I feel like that's not a great answer. Alex, do you have any thoughts?
Yeah, sorry, I was typing them. But I think the biggest thing is really advocating as best as we can for that kid. So whether that's as professionals and providers, we're attending a school meeting along with the family, like a 504 IEP meeting, where we can advocate and help recontextualize the behaviors. I think that's always a great option. If we don't have that option available to us as the provider, working with the parents on how they can advocate for their kid and also get like a disability advocate if they have, again, like an IEP, and just really helping them to support. Sometimes I've even worked with school professionals and I've given them the handouts that we use in PC Care. And I'm like, hey, this is what we're learning at home. These are the skills we're using. You don't have to use the same language, but I think it's helpful to know what we're doing at home. And we know that it's good with all kids if you want to incorporate some of the, language or the skills in your classroom, and I'd be happy to consult on how to do that and talk more. So just providing as much resource as we can.
Yeah, and that gives me another thought too. I am a big proponent of for the purposes of good, using people's standards and words and proclamations against them, right? So if we're thinking of a specific complex or whatever, I think overall, like the DOE has some like efforts. They want to be trauma informed. They want to be like culturally sustaining. They say these things are important to me. When we can identify that perhaps some of the things, the ways you're interacting are not the most trauma responsive ways to interact, that can be really helpful. Like the way I would think about this with a parent is I would provide a lot more psychoeducation about trauma, usually, because I'm not that every single kid I'm working with has a trauma past, but I would say 95% of the referrals that I work with do. So a lot of times it's contextualizing the behavior within trauma and understanding how trauma works. And if the school needs that, maybe they need that, right? Maybe that person doesn't have that, and you have more of a leg to stand on with a school than a parent sometimes, because at least the school has standards that they say they're working towards. They say, hey, we're trying to do this, and if your individual worker isn't on board, that's something that's like a gap you might be able to fill. Great question. Sorry if the answer wasn't very satisfying, but keep them coming. If you have more questions, feel free to drop them in the Q&A or the chat. Okay. So now to go to PC care in Hawaii, I'll start with just explaining some of our local PC care values. And these are essentially things that Alex and I have compiled after doing this for a while. I've had, I don't know, dozens of PC care family, quite a few. I've had a lot of PC care clients. Alex has trained a lot of people, supervised a ton of people, and now I'm training people and supervising them as well. So we have some thoughts about what's important going into training and what we want our trainees to come out of our training doing. And there are 4 things here, so I'll go through them one by one. The first, and I've said this a few times, culturally sustaining practices. It's at the core of everything we're doing. And the reason we say sustaining rather than competent or responsive, this is just like a pet passion project of mine, but if you say competent, it feels like a checklist that we can achieve. And we do have competencies, you know, for plenty of things, getting through grad school, becoming a therapist in certain things. But that's not what culturally sustaining practice is. You don't just check a list off and you're like, I'm cool now, I'm good, I never have to think about it again. If we're saying responsive, I think that's better, but I also think being responsive to something creates an inherent other, and that's not what we want to do either. So by being culturally sustaining, it means we want to come alongside you. We want to know what's important to the family in whatever aspects that means. Is it their religion? Is it their heritage? Is it just the culture within the family that can help us be good providers in that moment? And that's what culturally sustaining practice means at its core, but it can look like a lot of different things. Caregiver led, this is, like Alex mentioned earlier, part of being trauma informed. We want to be able to meet people exactly where they're at. And different families will have different levels of things like buy-in at the beginning. And so we are able to increase and support things like buy-in and commitment and willingness to try new things, their trust and rapport with the provider. If at the center of everything, we're acknowledging that the caregiver is an expert and they're very much in charge of what happens in this situation, and they're not just doing things because we said. Provider efficiency is kind of a weird one, but because this is a limited, brief dyadic intervention, we truly do not have time to dilly-dally, essentially. So we have limited time to cover a ton of content. By being efficient and knowing and having a plan and going in ready, it shows that we're honoring other people's time, and it allows us to get through the content that we have planned. It's also an opportunity to practice non-avoidance and really face whatever people might find intimidating, whether that's the parent facing something intimidating with the child or the therapist facing something intimidating about working with the family. We also have a do whatever it takes mindset. And I think part of that is, you know, for context, we both live on the east side of Big Island, and like things are rural out here. We got to get a little scrappy to make things work, and we want flexibility with infidelity. What can we do to make this intervention as accessible as possible while still achieving the core goals of the intervention? And so I think you could say this for a lot of different interventions, but with PC care, it's looked like a few different things. Like I had a family once who really couldn't get home in time to do the session, and just timing wise, it was challenging. So they started going to a Burger King and sitting at the corner of a Burger King and having session. And we had the best sessions we had in the Burger King compared to home, because the kid was contained. Like he couldn't move as much out of the booth. He couldn't bounce and run away. That was great. I worked with a family on Maui who didn't have a home. They lived out of their vehicle, and I had to make a ton of adjustments and accommodations to be able to do this content at all. I even had to adjust some of the resources on the fly, because it's kind of assuming, I think, that you have a place to live on some of the content. So that's why I would really like to make an appendix more specific to that community or people in that situation. And then all of this, but we're not at the cost of the provider's well-being. So even though we want to do what it takes, we don't want to do what it takes to the ends of the earth, right? We still want people, our trainees, to have their boundaries, to stop at the end of the workday, to take care of themselves, and not to like go so much above and beyond that this is unhealthy or cutting into their well-being. And then really built on a foundation of trauma-informed care and practices. So that's why this image is here. When we do training, we typically explain all of these. This is probably some things that y'all are all very familiar with, so we won't go into detail, but things like safety, trustworthiness, choice, empowerment, and collaboration.
Right. And then just kind of, again, contextualizing our local population and why we felt the need to come up with these values and be really intentional about it. Because it was really a specific meeting Stephanie and I had, and we said, okay, what's going to make this most appropriate for our really unique population? And so both of us work with CAMHD, which we know has folks who are qualifying for intensive level of mental health services. So we see high rates of trauma, which can affect, of course, the entire family and a large part of the community, depending on the type of the trauma. We also on our lovely East Big Island can see a lot of limited resources, and that's not specific to just East Big Island. I think that's what we're most familiar with, but we definitely see it on the other ones of like just being in a rural community, money or time, just that can be a real challenge. And then a lot of cultural or systemic mistrust. Again, we work for the government, so we represent this very formal system. And also both Stephanie and I are not from here. Stephanie, I think, has a little bit of an easier time with this. But me as a very like white person, I definitely, see that from families from time to time of what are you going to teach me? Or are you coming in here to tell me how to parent? And so that's why it's really important for us to be collaborative and build a team with the families we work with. I don't want them to think I'm coming in and just going to tell them how to parent and that I know better than them. That's certainly not our intent. And then a lot of caregiver concerns. So again, there's systemic barriers, so it can be hard to find access to any kind of services and then, get in and, work with them. They also might feel like they haven't been understood or validated, overwhelmed, again, feeling like they have no choice and voice in their own treatment and just kind of like people are telling them what to do and they have to go do it and they don't get a say. A lot of old school parenting approaches that, again, some are not problematic at all and they work well, but some that are maybe outdated, ineffective, or even harmful that we want to really work with the family to make sure their parenting skills are communicating their core values. And then sometimes we have families who come in and they tell us, I've tried everything before. I'm willing to do whatever it takes, which is a lovely mindset. But they also come in looking for something super unique or highly specialized. And I think they expect us to give parenting strategies that are like the secret sauce that no one's ever heard of that we happen to have. And unfortunately, the skills, are very basic. They're things like praise and consequences and choices, all things that I'm sure most families have heard before. But what makes it special is that we tailor it to their family and to their specific child. So we want to just make sure we're managing those expectations with families right as they come in, so they're not frustrated when our first session, we're teaching them the skill of labeled praise. Okay, and then local adaptations, just like a quick touch on this one, that we are aware of language norms in coding and coaching. One of the things we do is we do that observation and track all the parent communication, what they say to their child. And we do have a local adaptation here in Hawaii because a lot of folks here colloquially will add "ya" at the end of their sentences, which on the mainland turns that into a question. And so we would coach that for a family to say, oh, we want to avoid questions. But because here that is a very common way of people talking and most kids know it's not necessarily a question they have to answer, we don't have to code it as a question. So we're very mindful of that and teach our trainees that to be aware of it. We're very thoughtful in our case conceptualization of how to engage families most appropriately. Again, Stephanie talked about the flexibility within fidelity and then directly addressing that old school parenting as needed. All right, and I was talking quickly because I really wanted to get to this, our data. So this is, first graph is one of the problematic behaviors. So parents rate this every single week of treatment. And it's a scale of 1 to 7 of how often 9 different challenging behaviors occurred over the past week. And so we do have a clinical cutoff score of 45. And you can see at pre-treatment, most of our kids come in with a score of about a 40, which is above our clinical cutoff and very stressful for families. And by the end of treatment at session 6, we see it much lower. I think it's about a 29. So underneath our clinical cutoff range, much more manageable. Usually it's not just like one behavior getting a lot better. It's a couple behaviors that have all started to kind of decrease, and in just 6 weeks. Okay. And then we see this is our positive communication data. So the lighter blue line.
Sorry, I accidentally switched the colors when I did this, so just switch the colors.
Yeah,
Does that
lighter
make
blue
sense?
line is pride skill. Yeah,
Yeah.
I got you.
Pride
So the
skills go
colors,
up, avoids go down.
I got you. So again, the colors are opposite from what it looks like on here, but I've got it. So that light blue line that starts at 5 and then goes up to about 12 and levels out, that's our pride skills, positive communication, all the skills that parents are saying, you know, praising them, reflecting them, describing, saying they enjoy playing with their kid. So our families actually double their use of pride skills by about session 2, and then they maintain that for the rest of treatment. So once they have the skill down, they keep continuing to use it, even though we're not necessarily teaching those skills every session. We might be practicing, but we're not explicitly teaching it. And then the other thing our families are excellent at is avoiding the things we ask them to avoid. So at the beginning, they're saying a lot of things like questions, commands, maybe some criticism, usually not as common. Questions and commands are really big ones, or a statement with like, no, don't stop, quit or not. Like, don't do that, stop running. And then they decrease that. So they're actually, by the end of treatment, on average, saying more positive things to their kid than negative or than avoids in that 4-minute chunk. Where at the beginning, you can see that big disparity where they're saying a lot more questions and commands than they are that positive communication. So that one we're very, very excited about. And then this last one is a trauma measure that we do. So we give the ECTSS or the CATS, depending on the age range. And what's important here is that from pre-treatment to our last session, which is only a 7-week time span, families endorse an average of 3 less trauma symptoms by the end of treatment, which means they're just not seeing those happening anymore. And they're seeing the kids start to, you know, feel more comfortable and safe, and they're not having those big trauma reactions to the same degree. There's still some things going on. But I mean, for 7 weeks, that's just really, really exciting data for us. Okay, and then our local goals and future plans, we really hope to expand the availability and accessibility of PC care. Stephanie and I would love to train more local therapists, both within CAMHD system, but also within our community, our intensive in-home providers and things of that nature. We're always, you know, requesting feedback so that we can continue to improve, make sure that this intervention is meeting the needs of our community. That's, of course, most important to us. If we weren't seeing good outcomes, then we wouldn't keep doing it, but we're seeing it. So we definitely want to keep following up on how we can continue to serve our families. And then we are working on adjusting the examples in our handouts that we give to families to reflect more like relevant cultural examples for activities or strategies or just even the way the families talk. And again, continuing to collect and analyze data. I know we're just about out of time, but the one last thing I really did want to touch on was just with child welfare involved families. And I know Stephanie at the beginning had said what California is doing, and I just want to touch on what we hope to bring here based on that model. So in Sacramento, they actually offer PC care to every newly placed foster child within Sacramento County. So if they've been placed within 90 days, any child gets a referral to us, well, to them, and they call and they offer it because it is a preventative form of treatment. And so that is something Stephanie and I are hoping to be able to do to partner more closely with child welfare services in Hawaii and really support families to help kids have more stability in their foster parents' home, and also support on the back end when they're transitioning back home, getting their bio family back involved for kids who are working towards reunification, and being able to teach the bio family those same skills as well. Okay, sorry, Steph.
No, that was great. The other thing is, because it is can be a preventative type of treatment, you don't need to have any kind of license or anything to become full certified in PC care. And so I just wanted to share a couple of resources before we go to our panel discussion. One is this very cool, very free thing that anyone can use whether or not you're doing PC care. So I dropped it in the chat, but it's called the PC Care Learning Center. It's brand new. fresh off the SAMHSA grant, having this giant resource created that's extremely family friendly. And we also use it when we train our trainees to do this intervention. It's essentially all of PC Care made into an online module. So you don't get that same thing about direct like in the moment coaching, of course, but we can send it to families along the way as a reminder of the skills we're teaching them. There's lots of videos, there's more information about certain things. So it is a really, really awesome resource. I would recommend anyone using or checking out, even if you're just curious about like, oh, I don't really know how to address this certain kind of problem. You can actually click by problem and try to see how you might use these skills to address it. So I think it can be excellent for anyone who wants to check this out. It's totally free to make an account. They do ask a little bit of demographic information because it is funded by SAMHSA, so they're tracking some of that. All right, and then last resources is if you're interested in becoming a PC Care provider, it's not totally open to everyone right now. However, we are keeping a list of people who are interested for when it does open up. So if you'd like to potentially be trained by Alex and I, you can shoot us an email and we can keep you posted on future developments as they become available. But you can also be trained through the UC Davis center. They won't have those local values, obviously, that we talk about, but they'll have excellent training available to you, totally free, also funded by SAMHSA. And then, of course, the Learning Center. So we can move on to questions and panel discussion.
Excellent. Thank you very much. I think we give a round of applause. I know that, well, the Zoom participants can't be seen or heard, but I imagine they're doing that virtually. It is with great pleasure now that I would like to introduce Mr. David Gerber, who is a father of 2 boys and does full-time work in emergency medicine. He's lived in Hawaii Island in Hilo since 2013, and he enjoys playing in the ocean and camping with his family. He has graciously and very, very appreciative uh, agreed to serve as a keynote discussant to share his thoughts, and I'll allow him to introduce himself further and share whatever he's comfortable with. But now we turn to the more kind of discussion part where people can ask questions in the chat, maybe the Q&A. But I think first and foremost, we want to turn it to David. So David, I'll turn it to you. Thank you, sir.
Thanks. So, just to clarify, can I just give my experience with so I will say that I was a little skeptical when I first started this. I mean, I felt like, starting off, I felt like I was a pretty good father at baseline. I didn't need someone telling me how to play with my kids. But I felt like I played with my kids on a regular basis. But when I really sat down and thought about it, and I started seeing what we were doing with PC Care, I realized that when I was playing with my kids, I was, playing a sport or playing a game with like structured rules where we were like, this is how we are going to play. And there wasn't a lot of like unstructured play where they could play freely with me. And I was like interacting with them without a lot of rules. And when we started doing these things, we're like, okay, we're gonna just play with Legos, and there's no rules. You can build whatever you want, and you can't tell them what to do. And it just kind of it opened my eyes, like, okay, this is not how I was playing with my kids before, and how it was just amazing to see them interacting with me in a way that I hadn't really appreciated interacting with them before. And the rules that were placed upon me, like, you can't ask them questions, you can't give them commands and things like that. And Alex and 70 whispering in my ear, that was a question, and that was a command. Like, that was. And the more I got used to it, and the more I started not asking questions and just letting them do what they were doing, it just kind of like blossomed. It was so much fun. And at first it was like thinking like, oh man, I have to like structure in time my day to like play with my kids for like 5 minutes a day. But then I realized, oh man, it was fun, and the kids love it. And like, oh, they set a timer for the days. Oh, it's time for a special time. We bring out the Legos and we play with Legos, and the kids, they're very smart, and they're very observant, and they'd be like, oh, Daddy, that was a question. uh, Daddy, that was a command. Like, oh yes, sorry, that you're right, that was. And so it was great just watching them and playing with them. And we continue to do that, not as often as we were doing with the session, but now we make time to have these um, opportunities to play with them in this kind of unstructured way. And having Alex and Stephanie point out these things that I was doing that you don't even realize that you're doing, but it really does make a difference in how we can communicate with our kids, and it really is eye-opening. And he's giving me faces right now, but it was, and again, I felt like I was a good father and I communicated with my kids, but it really did help my relationship with them. So I'd be happy to answer any questions about that.
I also want to clarify, you are a wonderful father, David. There was never any concerns that you were a bad father by any means. You were excellent. But it was just such a joy to watch you guys play together. Stephanie and I still talk about how just precious you guys were.
Yeah, and I want to provide a little context. So this is the graph that I'm Jamie, I guess I'm putting you on blast too. But Jamie and David very graciously volunteered to do full PC care with us for the purposes of helping us build some training videos, because we need some videos of some kids to show our trainees, and we need non-client videos. So they did that for us, but we also were able to just do PC care with them. And so you can see that even two highly educated, extremely capable parents made amazing improvements in how they use pride skills. So David is orange, Jamie is blue. They were kind of competing against one another to see who could use more pride skills during observation. So that I think helped too. And then behaviors you can track. So usually when we show this to parents every single session and show them their progress as we go. And we try to say usually we want this to go down, we want this one to go up. Often that happens in kind of an inverse because you are using more skills. So great job on your excellent data. And we did see some improvement go down for the kids over the course of time.
I think I see this question about videos. I don't know if you even have anything queued up, but I think we did get permission for that.
Oh yeah, with the two of you, we definitely do. And I'm happy to show, because Alex and I were making transcripts of all of these videos for the 4-minute chunks to let people practice coding, and it's very cute. So I'll let folks chime in if you had other questions. I saw there was a raised hand, but I'm seeing that also we may not be able to unmute you. So I'll pull that up while you'll type in any other questions you want.
And I think just, one thing I'll touch on while we're waiting for more questions and for Stephanie to get a video up is just how much this helps again with child welfare of giving kids stability. I've worked with kids before who had bounced from one foster home to another and had a really hard time maintaining consistent placement. And then by, our third round of PC care, we were able to get them stable and staying in a placement because the family knew how to manage the behaviors a little bit better. And I remember one little girl I worked with, she was only 3 at the time. And our first session of PC care, the foster parent said, they want us to be the adoptive parents. We already know that, but we don't know if we can make it another week with her. It's so challenging. The behaviors are so big right now. And I said, well, let's just hang on for 6 weeks. Give me 6 weeks to see what we can do. And we'll see where we get. And she stayed that whole 6 weeks, which was lovely. And then we followed up after 1 month and she was still there doing well. And then 6 months in, they had actually chosen to move forward with the adoption and permanency for her. So it really does make a difference, helping kids find that stability and find a family that can meet their, unique needs, which is great.
Yeah, and I think I don't know if you talked too much about this, but the data from the California group that's been doing this longer is showing that they're able to stay in a foster placement longer, that they're able to stay with their bio parents, that the ability of the kids and parents to maintain that consistency improves over time with this type of treatment. And I'm hoping we can kind of get some of that data more long term for our CAMD kids. It's a little bit tricky because of like HIPAA and that kind of thing. But our ultimate goal is to help kids build that stability and consistency, especially our kids who are in the foster care system and have so many of those struggles, and tend to have more difficulties with behavior problems and maintaining that kind of support because they don't have consistency. And that's really hard, I think, for a grown-up, let alone a kid who's experienced trauma. So we're really hoping that we can expand this program so we can support more of those kids.
Yeah, and I see Pua's question. I can answer that really quick, Pua, of what do I mean by the third round of treatment with some of my kids who are kind of transitioning between placements. So when I would start PC care with them at one placement, and then when they would move, I would restart again at the next placement. So for a period of time for multiple clients, I was kind of their one consistent person for a little bit. Not that they remembered me because they were like 3, but I had a really big toy bag that was zebra print. And as soon as I walked in with that, they were hyped. And so I was able to kind of follow them from placement to placement until we were able to get through it all and see it the whole way through. Yeah, thanks for asking.
While there's a brief break, I just wanted to share how proud I am of Stephanie and Alex for bringing this to Hawaii and being, amazing trainers and advocates for kids and families and, being PC care experts. I'm very peripherally kind of minimally involved in this effort, and yet it's one of the things that I'm like very, very proud of CAMD starting to incorporate more into kind of what we do. And I'm hoping it just kind of continues to blossom and grow because you two are very, big advocates for this, and you've really kind of revolutionized some of our services in some really good ways and making it more preventative and, accessible to younger kids and more family focused and culturally responsive and a lot of the things that we espouse. So anyway, I'm just like really, really stoked to have you guys here and bringing this treatment and advocating for it. And so anyway, proud, very, very proud to work with you guys.
Thanks, Kurt. While y'all think of any other questions, I do have a clip for you. So I'll play the last half. And I wanted to just show you what this looks like when we're kind of doing these transcripts to train folks. We have this out, and then we usually ask people to try coding without the transcript first, because that's more what a normal session is. But if you're trying to really figure out where people might be making mistakes, it's really helpful to be able to see what they're coding. And so, yeah, I'll play a couple minutes of what a playtime looks like. And this is session 6. So David's got lots and lots of skills at this point.
Right there on top. Good. I like it.
Just like that. Maybe we should put this a little more forward.
Yeah,
This
a little
there.
forward.
Put this up there. But like that.
Ooh, yeah.
Still touches.
Perfect.
Yep. Now.
Nice job. That's some good problem solving right there.
It's a look, I found a dirt block.
Sweet. Oh, look, it's a crab. I'm gonna make a crab vehicle. All right.
That's one, and that's 2.
Ah, they're gonna put some wheels on it, huh? Perfect. Boom.
Okay, now just face upward. Oh, I see why it's doing that. It's not tall enough.
Ah, nice observation.
Should we add in this little grass block? Yeah, you got nature a part of it. You got piece of nature.
Yeah.
Oh, Virginia, nature, 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 Virginia. Oh, well, this needs to be really, really high. Okie dokie, I bet you.
Hmm. Wheel to go on my creation here. I love what you're doing with yours. Oh, look, Princess Leia has been hanging out on mine.
Hey, that was a question.
What was it? What was the question?
Oh, look.
I'd say it was more of a command.
I love that he knew that was a question. And so, yeah, that would be during our coding, our observation of it. So that's why my camera was off during that portion. And then when I come back on, we spend just a minute giving feedback right as we're finishing up. And so I do see Brad in your question, who codes the videos. In the moment, we code them right as we're working with the family as they're talking, which is why we practice with our trainees a lot, because you have to be able to do it live in the moment to get the scores so you can talk about it at the end. And then I just thought I'd give it like an example of feedback. Normally something that we're talking about is like the number of pride skills they used and then what we observed and how the child responded. So I didn't watch that whole 4 minutes again, David, but it'd be something along the lines of really great job today. I heard you use 15 pride skills because I remember David ended with 15. That was so awesome. He was so engaged and calm and really focused on what y'all were doing together and had a lot of opportunity to lead. And so that would be kind of what I'm touching on. So I want to talk about like objectively what I coded, what their scores were, so we can talk about that progress. And I also want to highlight the skills used and how the child responded to that. So I think that's what's most important is because you use the skill, what is your kid doing as a response to that? It's not working because I say it's working because we see your child right now responding to it right there in the moment, which can be so hard to miss as a parent when you're thinking about the skills you got to use, what I'm going to be saying at the end of it, what your kid's saying to you right now. You've got so many things you're thinking about. Those small moments of how it's working all together can really easily be missed. So that's why we want to be really clear with our feedback to point that out and help families see that connection. And then Brad, for your other question, what the referral process is. Right now it's for CAMD kiddos only, unfortunately. But we do have just like an online referral form that we give to MHCCs to fill out when their clinical team has determined that this would be an appropriate treatment. So if you are CAMD involved, or if you have families who you think would be a good fit who are CAMD involved, you can definitely like reach out to their clinical team and we can definitely pass along that referral form.
Awesome. Thank you so much.
Yeah.
As we're kind of rounding things out, some other to bookend with some housekeeping on the continuing education units, whichever email you use for registering for today's roundtable, please be on the lookout for a feedback survey that we'll be sending to that email address. You'll need to fill out that survey if you signed up for social work CEUs. So social work CEUs are based on attending at least 90% of today's roundtable presentation and filling out the survey. However, even if you haven't signed up for CEUs, we would deeply appreciate you filling out the survey as it has questions for feedback and satisfaction and trying to improve overall roundtables in the future. In addition, HPA, with the support of the Hawaii Behavioral Health Connection, a program of HPA is co-sponsoring this roundtable and offering free continuing education units for its HPA members. So thank you to HPA as well. Want to turn it over to maybe David, Stephanie, or Alex, or Jamie, or anybody else for closing thoughts. But before that, just wanted to express our deepest appreciation and gratitude for today's presentation. I thought it was stellar in all regards. So I'll turn it over to Camby for the last word or closing thoughts.
Thank you. And I did just see one last question in there, if I could just squeeze in an answer super fast about why questions aren't very helpful. I think Stephanie just answered it, but essentially they don't really allow the child an opportunity to lead in the moment and can feel frustrating. And most families are asking questions for one of two reasons: to engage in conversation or promote learning. And our pride skills that we teach can do that more effectively and avoid kind of the frustration. And I explain it to, the parents we work with is like, if I'm at work sending an email and someone's over my shoulder, like, who are you emailing? What are you doing? Why'd you say it that way? When are you going to be done so we can go do lunch? Like, I'm going to be really irritated and ask them to please let me finish what I'm doing. And kids feel similar in play. So we have some skills to replace questions so that we can still promote learning, still engage in conversation, and let the child lead so it's more positive. And I'd be happy to expand on that more if you want to reach out to us. I think you should have our contact info. And then since I'm unmuted, I will also say just thank you guys so much for having us. Stephanie and I love talking about PC care. Any chance we can get, we're really, really proud of it and just really excited to see how it's been helpful to our families in the community and how we've been able to meet a need over here, especially with that younger age range. So we're just super excited about it and really love talking about it any chance we can get. So thank you for having us.
Thank you so much. I'm very grateful that I get to work next to people like you. So it's amazing. You're doing great work. Thank you.
All right, I think, turning it to Jamie. Jamie, close this out. I saw you on mute.
Oh, I just was gonna say Stephanie and Alex are amazing. And really glad to have them as well. And I hope that we can do everything possible to make this program more available in the state.
Thank you for having us, and thank you so much for everyone's engagement and attention.